Okay, so look, I'm pleased to introduce Dr. Sarah Anderson. Sarah is a senior transplant dietitian here at Royal Brisbane and Women's Hospital, and also a Metro North Clinician Research Fellow. She has a strong interest in research, investigating nutrition during cancer treatment, and completed her PhD at UQ on nutrition support during allogeneic stem transplantation in 2021. Her work is focused on investigating the use of enteral and parenteral nutrition, the influence of nutrition on the microbiome and changes in body composition and energy expenditure during transplantation. Thank you.
Hi, everyone. All right, thank you so much to the organisers for the invitation to present today. So let's just move the slide. Okay, so we know that patients have a terribly hard time eating during an allogeneic transplant due to the intensity of the treatment. And they really frequently require some extra nutrition support to prevent deconditioning and malnutrition developing. And historically, parenteral nutrition has been used really frequently. When I talked to each transplant unit around the country as part of my PhD, we found that 50% of Australian transplant units were using enteral nutrition and 50% were using parenteral. So there's really no consistency in practice. And I think historically this is based on the fact there hasn't been a great deal of research on enteral nutrition and whether it's tolerable in this patient group who develops a lot of gastrointestinal toxicity. We did some research here at the Royal a few years ago, and we ran a randomized control trial, and we compared the tolerance of enteral feeding and the outcomes in comparison to our usual care, which was parenteral nutrition. And what we found was that 50% of our patients could tolerate enteral feeding when it was started proactively the day after transplantation, so starting before all that mucositis and a lot of that toxicity develops. Other studies have reported quite similar tolerance and slightly higher, around the 67–70%. We didn't see a difference in clinical outcomes in our study, but there have been a few other observational studies that have shown some potential benefits with enteral feeding. So some studies have shown faster neutrophil and platelet engraftment, reduced risk of GVHD, potentially shorter duration of fever, reduced need for antifungals, lower rate of transfer to ICU, fewer hemorrhagic events, less catheter removals, and less hypoglycemia and mortality. There have been I'd say the data on GVHD and mortality is really quite varied. There's a few studies that have shown no association at all with the type of nutrition support. So no studies had really looked at, does the type of nutrition support that we provide to our patients during allogeneic transplant impact on the microbiome? So there's a lot of studies, as many of you will be aware, on the microbiome and links with clinical outcomes after transplant. Some studies have shown things like diversity, microbial diversity and engraftment is a predictor of mortality. One study showed high levels of the bacteria blota associated with reduced GVHD mortality, and blota levels declined with a longer length of time on parenteral nutrition. And a couple of observational studies have shown associations between poor oral intake and GVHD development, but no studies had looked at enteral feeding. So we ran this as a sub-study of our randomized control trial, and patients that provided a stool sample a month after transplant participated. So these patients had been randomized either to early enteral feeding or to standard care and with parenteral nutrition. And we analysed the stool samples with shotgun metagenomic sequencing. So what we found was that our enteral group had more potentially beneficial bacteria, so bacteria associated with short-chain fatty acid production. We also found our enteral group had less proteobacteria, less Klebsiella and Enterococcus. We didn't see a difference in blota or in overall microbial diversity. In terms of clinical outcomes, the patients that had additional beta-lactam antibiotics had lower diversity. We didn't see a difference in GVHD in terms of the microbiome, but we also had very few patients with GVHD in this cohort. In terms of length of stay, we saw some interesting data. So patients who had a longer length of stay, so over 30 days, had lower levels of blota and higher proteobacteria, Klebsiella and Enterococcus. And we could see that in the PCOA plot, that the overall microbial profile depended on length of stay. The groups were quite different. And in the box plot, you can see how different the diversity was. So based on the work that we'd done and the other literature, the other studies that had been published, we did change our standard care here at the Royal Brisbane in 2019, and routine enteral nutrition proactively commenced on day +1, replaced routine parenteral nutrition. And we analysed the outcome of that at 12 months and at 2.5 years. And I'll give you a snapshot of the 2.5-year data now because this was a much bigger cohort. So it was part prospective, part retrospective chart review. We collected data on nutritional status and type of nutrition support, and we were able to use all the baseline characteristics and outcomes from the transplant database. And because it was a reasonably sized cohort, we were able to do some regression and adjust for the baseline confounders. So I won't go into the baseline characteristics too much, but the groups were really quite different. So we had 167 patients who had enteral nutrition only over the 2.5 years. We had 25 who received parenteral and 54 had started with enteral and then needed to change to parenteral due to poor tolerance. So conditioning, there was a lot more fludarabine melphalan conditioning in the enteral group. In terms of donor, we had a lot more unrelated donors in the enteral group, a lot more haploidentical donors in the patients that received both forms of nutrition. There was more AML in the enteral group, more ALL in the parenteral group. There was a difference in nutritional status. So we had a lot more patients who were malnourished at the time of transplant in the enteral and parenteral group. But that's potentially due to our protocols. So if you're malnourished and you fail enteral feeding, you're more likely to receive parenteral nutrition. And in terms of HCTCI, it was interesting here that we saw more patients with a high score in the parenteral nutrition group compared to the enteral only or the patients that received both. So this is the unadjusted data. We saw there was a longer total feeding duration with the patients that received both forms of nutrition, so a median of 20 days compared to 13, 14 in the other groups. In terms of length of stay, there was a median of 19 days in the enteral group and 21 to 26 in the patients that received parenteral nutrition. In terms of days to neutrophil engraftment, 14 days in the enteral group compared to 17 in the groups that received parenteral feeding. And a similar trend for platelet engraftment, so 18 compared to 22 to 24. We didn't see a difference in GVHD rates. We did see a difference in disease relapse, so 20% in the parenteral group versus 6 in the enteral and none in the patients that received both, and no difference in survival. And this is what the data looks like when it's adjusted for those baseline potential confounders. So feeding duration was still significant. So it's a 32% longer feeding duration in the patients that received both forms of nutrition compared to enteral only. Length of stay was still significant. So 24% longer length of stay in the patients that received both forms of nutrition compared to enteral only. And in terms of days to engraftment, 11 to 16% longer in the patients that received parenteral nutrition compared to enteral only. And a similar trend for platelet engraftment, 20 to 24% longer days to platelet engraftment compared to for those that received parenteral nutrition compared to enteral only. And the numbers were too small to be able to look at disease relapse in a multivariate model. So this data was super interesting and it really reinforced our practice that we are doing the right thing. We should be really giving parenteral nutrition only if enteral is not tolerated. And the tolerance was really interesting. So in this 2.5-year cohort, 75% of our patients are tolerating enteral feeding and not needing parenteral, which is fantastic and higher than we saw in our clinical trial. So our reflections after this study were really, so we know that a majority of our patients can tolerate enteral nutrition, but how can we optimize the formula that we're providing to best support the microbiome? And can we help to maintain gastrointestinal barrier function during a transplant? Can we give a formula that contains some prebiotic fibers and will that help improve patient outcomes? So that's led us to the study that we're just finishing at the moment, and that's been looking at tolerance of a prebiotic fiber containing enteral formula. And we've been looking at microbiome, metabolomic and clinical outcomes of that, and we'll have some outcomes of that to present to you really soon. And in terms of the studies that we're planning at the moment, we're going to be having a look at prebiotic fiber supplementation for patients who are newly diagnosed with acute leukemia. So really trying to do a really early intervention to protect the microbiome right from diagnosis. And we'll also be looking at another study on prebiotics during transplantation. And again, a bit of an earlier intervention, because by the time we start enteral feeding, it's day 1 after transplant. Patients have already had 1 or 2 weeks of chemotherapy and antibiotics and many other insults to the microbiome. So really trying to put a supportive measure to support the microbiome from that earlier time point. I'd like to acknowledge the research team that have worked on all of this. Andrew and Glenn have been very involved, as have Marilyn and Judy and QMRB for their support with the statistics. Happy to answer any questions.
It's very exciting stuff, seeing this great work being translated so quickly into clinical practice. Are there any questions in the room? Are there any clear risk groups for people who are likely to be in that 25% who can't tolerate enteral nutrition so far?
It looks like some of the patients having the haploidentical conditioning regimens were slightly less likely to tolerate it, and that's probably because they receive chemotherapy after their transplant frequently. Whereas with the other regimens, it's you're past the point of all the conditioning therapy, so the side effects like nausea and vomiting are more likely to have resolved by the time they start enteral feeding, whereas the patients who are receiving chemo later are more likely to have those side effects later, therefore are more likely to vomit and lose their nasogastric tube. But at this stage, they still receive enteral feeding from day +1 if they're having that type of, if they're having a haploidentical transplant. But if they have completely out of control nausea and vomiting at that time point, sometimes we delay tube placement for a day or two, just until things have improved. The question was, would fibre supplementation be a one-size-fits-all in the transplant population? I would say no. So the more reading that I do, the more I believe that people's microbiomes react differently to different fibres, and some fibres will benefit some people, some fibres people will tolerate better than other people. So really, this research is still very early in knowing what is the best types of fibre that are going to support the most microbiomes. Do we need a blend of fibres is probably a potential likely outcome, and what are the doses that are going to be of most benefit and still be really tolerable? We don't know yet.
Can I just ask, are you planning to look at any other readouts for like barrier repair or readouts in terms of immune cell function changes in your study?
I missed the last bit, was it?
So any immune cell modulation as sort of a readout for repair to the barrier or repair to reducing GVHD? Yeah.
Still very much planning that at the moment, but we will look at short-chain fatty acid levels in the stool and in the serum. We will probably have a look at citrulline levels to have a look at gut barrier function from that perspective, and we will have a look at some immune markers as well. So I'll have a look at cytokine levels and some T cell subsets and things like that. So they're the things that we're sort of thinking about, but very much in that planning stage.
Congratulations, great work. I'm sorry if I missed this, but have you looked qualitatively at the views of the patients as well as the clinical staff about enteral nutrition and what their views are, how enthusiastic they are to support it?
We haven't here. It has been done, and I think it was a group down maybe Sydney way did publish a survey where they'd asked about enteral feeding and whether the patients thought it was beneficial and whether they'd recommend it. So yeah, but no, not as part of the work here.